Welcome to the Dizziness and Balance video series by the Ear and Balance Institute. I am your host, Dr. Gerard Gianoli, and I am a board-certified neuro-otologist. Neuro-otology is the medical specialty that deals with inner ear dizziness and balance disorders. This video series is intended to be educational and not intended to be medical advice. For individual medical advice, please speak with your own physician. Welcome back. In this episode, we're going to talk about something called vestibular neuritis. It's been called by a number of different names: labyrinthitis, vestibular neuritis, acute labyrinthine syndrome, acute vestibular syndrome. In any event, it has been listed as one of the most common causes of vertigo. Now, I'm not sure I would label it that. I think the king of that is benign paroxysmal positional vertigo. But it's probably the most common cause for vertigo to present to the emergency room. Well, what happens with vestibular neuritis? The patient presents with severe vertigo and dizziness, nausea, vomiting, and it's so bad that typically they will present to the emergency room. One keys is that there is no hearing-related symptoms. There's no loss of hearing, tinnitus, fullness in the ear, that sort of thing. It's strictly vertigo, nausea, and vomiting. What are the symptoms? The symptoms are, as I mentioned, nausea, vomiting, vertigo, and this gets very severe very quickly. This is typically in someone who's never had any vestibular problems before. This is out of the blue. It can last hours, days, even weeks before any significant improvement in the condition. Probably the most important thing, though, is when you go to the emergency room to be evaluated, is that the doctors evaluate to make sure that this is not a stroke or an intracranial bleed. So they will typically do a scan or do some fairly good physical exam to make sure that that does not look to be the case. Well, after the acute process of vestibular neuritis kind of goes away, you get into some other symptoms you'll see with this. Number one, these patients will also get BPPV. And if you aren't familiar with BPPV, we have a video on BPPV as well. But what you'll see is you'll see little tiny short episodes of vertigo with different positional changes. It's very common to see this after vestibular neuritis. That frequently will either go away on its own or will be treated by a practitioner who can do something called cannula 3 positioning maneuvers. Then we get into the chronic phase of vestibular neuritis, which is when the patient's not having these severe vertigo spells, but they feel off when they move their head back and forth or what have you. And that will take a long time to resolve. For some patients, it can take many months, others a year or even longer, and there are some who will have residual symptoms permanently depending on the severity of the damage that was done. Well, what is the cause of vestibular neuritis? It is believed to be it is a viral infection of the balance nerve. It's similar to what we see in patients who have had shingles. Shingles, as a lot of you know, is originally from a virus that caused chickenpox when you were a child. When the chickenpox went away, it didn't really go away. It went into hiding in the nerves. And shingles is that virus kind of reactivating itself just in one nerve. Well, that's what vestibular neuritis is. It's the reactivation of a virus that's probably been there for a long time. And what happens is as the virus replicates, it causes swelling in the nerve. The vestibular nerve goes through these very narrow bony channels in the inner ear. And as the swelling expands, it expands beyond the ability for blood to get pumped into the nerve, and it basically sort of chokes off its own blood supply and causes death to part of the nerve. How is it diagnosed? Well, first of all, it's diagnosed with a typical history. As I mentioned, it's classically someone who's never had vestibular problems before. They have a severe onset of vertigo, no hearing loss or tinnitus, and then there's testing that needs to be done to confirm this. Imaging, as we mentioned, to rule out other bad problems that can mimic vestibular neuritis. But then two other aspects. One is a hearing test to make sure that there is no hearing loss. If there is hearing loss, well, then it's not vestibular neuritis, it's something else. The other is vestibular testing. In someone who has had vestibular neuritis, they will show evidence of a loss of vestibular function, usually quite substantially. If there's not a substantial loss of vestibular function, again, it's probably not vestibular neuritis, it's probably something else. It can be confused with other inner ear disorders that are presenting for the first time. One of the more common ones we see is Meniere's syndrome, and the first episode of Meniere's syndrome can be quite severe and can mimic vestibular neuritis. There's a whole bunch of other vestibular disorders. With the very first episode, it can be considered or possibly confused with vestibular neuritis. The big distinction between the two is vestibular neuritis very rarely comes back. It's sort of analogous to Bell's palsy or shingles, where you get it once, you usually don't get it a second time. Certainly it's possible to get another time, but it's pretty rare. So when someone has episodes of severe vertigo, you have to think about something else other than vestibular neuritis. How is it treated? Well, as I mentioned, these folks will present to the emergency room with persistent nausea and vomiting. So very often, the biggest concern is to prevent these people from getting dehydrated. So intravenous fluids, or what we call supportive therapy, is the first part. We will give the patients nausea medicines. If we can catch this early, within the first day or two, treatment with antiviral medicines may be helpful. But the one medication that's pretty much universally agreed upon in treating vestibular neuritis is steroids. And what we find is steroids will reduce the swelling and help reduce the damage to the inner ear, and these folks will ultimately have better outcomes long term. Subsequent to that, when the patients develop the BPPV, those little short episodes of vertigo afterwards, they can be treated with cannula 3 positioning. So a very classic presentation for vestibular neuritis is one really bad episode of vertigo. It slowly gets better, and then you get these little tiny spikes of vertigo afterwards. Well, once that's controlled, then the process is getting the brain adjusted to the loss of balance function, and that's where vestibular rehab therapy comes in, and where a good physical therapist is a godsend, helping the patient do exercises to allow their brain to adjust to this loss of function. Can it come back? As I mentioned, it's typically a one and done kind of thing. It can come back, but that's pretty rare. Just like, as I mentioned, shingles and Bell's palsy, yeah, it can come back, but that's pretty unusual. In any event, vestibular neuritis is a viral inflammation of the balance nerve causing a single episode of severe nausea, vomiting, vertigo without any hearing-related issues. It typically sends the patient to the emergency room, where they really should rule out life-threatening causes. The prognosis is generally good, but it can be quite prolonged for those who have severe loss of balance functions, and the duration is variable. This can be treated medically early on, but if you catch this patient even a week later, probably those medications to try and reduce the severity won't work. As far as we mentioned, recurrence is unusual, and if you do have recurrence, you should see your doctor look for another cause other than vestibular neuritis. And that's pretty much it for vestibular neuritis. Thank you.